All right, so I'm just getting the screen share up and going now. Can you just confirm that you're able to see that, please?
Yep, can see it full screen, Mitchell.
Awesome. Well, thank you so much for that and really appreciate you all joining. For those of you that's your first one, welcome. For those of you who went to the introduction, welcome back, and I'm glad you're still interested. So we'll jump right in, starting with part one today. It's going to be kind of why telehealth is essential. What do we use it for? How does it impact rural communities? And just a disclaimer that anything that we share, it's the opinion of myself and Gary Beck, who is going to be the co-presenter for today. Although we may use samples and examples of what we do at Renowned Health, anything that we share is our opinion and is not necessarily the opinion of Renown. So we just want to make sure that it's clear up front. If there's anything that you don't agree with, come talk to Gary and I, don't come talk to Renown. So introduction of myself, I'm Mitchell Fong. I'm the director of telehealth. My passion and history with telehealth started about 10 years ago. Actually was doing my master's research in public health on the need for telehealth in rural Nevada. And at that time, it's crazy to think that at that time, Nevada as a state was ranked 48th to 51st across the board in provider access. And today, that fact remains the same. And so I think with that being said, knowing the rurality of our communities, which we'll get into, it's a huge passion of mine to think about how do we reach 100% of the patients in our community to make sure everyone can get the right care at the right time. And Gary, I'll turn it over to yourself to introduce yourself.
Gary, you may be on mute still there. Go ahead.
I got it. Thank you, Troy. Thank you, Mitchell. I appreciate the introduction and the opportunity to get in front of all of you today. I'll start with just a little brief history about me and my history and experience in rural health. I currently serve as the Director of Rural Health Services and have been in this position for about 3 years and 5 months. And prior to that, I served as the Director of Business Development for Renowned Institute for Heart and Vascular Health for a little more than 7 years. Part of my duties with that group were to oversee their rural outreach cardiology clinics, at which time the group had 9 rural outreach clinics that they provided in-person services to. And then prior to that, I was in a similar position and role with a private practice cardiology group in Reno for 19 years until they integrated with Renowned Health in 2011. At one time with this group, they had 18 different rural clinics throughout this same area that I'm going to describe in a little while, that they either flew to or drove to provide in-person cardiology services. Then prior to that, I was a pharmaceutical representative and my territory encompassed all the service area that, again, I'm about to describe, and parts of California that are not even shown. So for more than 31 years, I've been working and serving in this entire area, based for the entire time here in Reno. I have thoroughly enjoyed working in this area and hopefully have provided a valuable service and representation to all these rural communities and hospitals. For me, it's been a privilege and an honor to serve each and every one of these hospitals and communities. Like Mitchell, I have a passion for rural health, and hopefully I can continue to make a difference in the health and healthcare of these communities and hospitals that we serve.
Awesome. Thank you, Gary. So we'll jump in today's agenda. We have already hit the introductions. So we're through that bullet point, but we're going to go a little bit over what is telehealth, what are some different technology modalities, and then talk about really specific to this region, why is it important? Open it up for questions, answers then. I will say we want this to be valuable for you. So if you have questions throughout, go ahead and use the raise hand function, and we can try to track that, navigate that so we can interject as it pertains. We'll also try to pause intermittently throughout to open it up for questions. So you don't have to hold them all at the end, but we're excited to have an engaged discussion here today. So I start with the question that I get asked most frequently is, what is telehealth and what is telemedicine? And furthermore, as of today, it starts asking, what's digital health and virtual care? And so really, I think digital health is any technology that is used to deliver healthcare. But today we're going to focus more on telehealth and telemedicine, where telehealth is the use of telecommunication technology to promote healthcare, whether it's education, clinical delivery, navigation, any of those. Where telemedicine is really a subset of that, focused on the clinical delivery of care. And so when we think about something like remote patient monitoring, that's something that falls into this gray area of what is it. And so a lot of times people define that as a general digital health strategy. It's not always embedded in telehealth because it doesn't use some of those telecommunication technologies when it's just the embedded biometric devices. But for our presentation, we'll include that in because we know that's a hot topic. And I think over time, that'll be included into the scope of telehealth and virtual care. So as we move forward to what are the different modalities, we have asynchronous modalities, excuse me. That's the ability to store and forward information. So let's say a patient has a wound, they take a picture of it, they send it to the provider. That's an example. If you're taking a sound using a stethoscope and you can record that sound and send it over to a provider, that's another way that we use asynchronous store and forward technology here today in the telehealth space. And then there's synchronous. That's what we're doing right now, a real-time interaction, live audio video interaction at the time in the moment. And that's just kind of an example of what this can look like using one of our clinic carts. And as an example, we also have direct to consumer modalities. And again, asynchronous and synchronous, that just determines the timing. These next modalities are going to determine a little bit more of what's the type of service, how do those work? So when we think of direct to consumer virtual visits, that's where a provider or a care team member is connecting directly to a patient using a patient's device, and the patient can be located in any location. Obviously, we're going to ask that the patient's in a private location, whether that's in their car, whether that's in their office or at home. It doesn't really matter at that point, but we are connecting directly to the patient to give them the right care at the right time. This is an example of what that may look like if the patient is just connecting with the provider. And then some other examples of provider to provider communication that can happen in the outpatient, in the inpatient, and in the field when we really think about that in the future. So there's consults. When we think about on-demand consults, we typically think about a telestroke or a telesite consult in a hospital. If a patient comes to the ED, they're a potential suicide patient or at risk for harm, they're going to require a telepsychiatric consultation. And we know that today, a lot of times patients are held in an observation status for multiple days just because there isn't that capacity to get a psychiatrist on site for some of those rural communities. So the ability to do a telepsychiatric consultation can expedite that time, particularly if that patient has no other clinical medical needs besides that psych evaluation. Telestroke will go into in a later program. I think session 2 or session 3 will highlight it, but it's really about getting timely care in the moment. And when we know about that 4.5-hour window for treatment, is their ability to treat that patient or initiate that treatment when they're at their distant or rural site and they're further away from where they may get transferred for escalated care. Office visits, we can think about urgent care, primary care specialties. I'm sure you guys are familiar with some of those, but the difference between a direct consumer connectivity there and an office visit is you're going to have the patient come to a local facility. Typically, this is how we work with a lot of our rural partners is whether it's because a challenge with technology, challenge with broadband is what we hear a lot in particular Nevada communities is patients cannot support a video interaction, whether it's their device or whether it's their internet that can't handle it. So they go to their local clinic, they get presented from that clinic where we have a stable connection with them. We have that hardwired connection to the cart. And furthermore, we have a trained presenter that can use some different tools to help present the patient, whether it's an exam camera, a stethoscope, or just be able to take the vitals in real time and tell the provider what the vitals are at. Triaging, we can think of outside the ED. And during the time of COVID, we actually used triaging a lot. We set up a tent outside the ED. Anyone with respiratory COVID-like symptoms were put into that unit prior to even coming inside the building so we can isolate. From there, we had a PPE gowned up staff that would complete an assessment and then present the patient to an ED provider So we can triage the patient to determine what's the level of care that they need. Can we streamline, get a private room already ready, and ensure there's a clear pathway for that patient to go in for that care? Just ideas and thoughts of how you can use triaging through telemedicine, tele-ED, EICU, ways that we can connect to deliver further care and support in those rural communities. And then remote monitoring and sitters are just passive ways that we can collect data or watch patients on a screen so we can ensure that they're getting the right care at the right time. We think about sitter programs. Historically, when you staff that physically, you're going to have one sitter for probably 1 or 2 patient rooms. When that's not very cost effective, especially if you're in a rural community. And we think about, well, I want one sitter to watch all of my inpatient rooms. And so using a telesitter capability, you can actually have video on them and audio in that room so that you can not just be watching that patient at all times, but you can potentially be proactively watching many patients at the same time. And you can use technology such as ambulation monitors and sensors that can tell you, is the patient laying down? Are they on their side? Are they sitting up? Are they standing up? And particularly if it's a patient that you're monitoring for fall risk, as you see them start sitting up or trying to stand up, that may mean let's intervene, let's put a nurse in that room and see what we can do because they are a high fall risk patient. So just to show a few
Mitchell, sorry, real
samples of this.
briefly, Seema does have a question.
Yes, would you go to previous slide, please?
Sure.
So would you define the difference between real-time interaction and virtual visits? What is the difference?
So there's not a difference there. The top two, asynchronous and synchronous, are two different ways that you can use telemedicine. One is where you store and forward information, and
Right.
one is we're using a real-time interaction. When you're
True.
doing any of the below, virtual visits, consults, office visits, those are typically all going to be in synchronous, real-time, where you're interacting over audio and video. There may be some asynchronous modalities included, where let's say telestroke, for example, we're going to have a real-time audio and video conversation between the neurohospitalist and the bedside provider there. That part will be a synchronous connection, but then the head CT and scan might be done 5 minutes prior and sent over. So that would be an asynchronous modality used in combination to provide that consult. And so virtual visits, you're likely going to just be having primarily synchronous interaction with the patient, but there are times where a patient can take a picture of a wound and send it to you during that virtual visit. And so you'll be using some synchronous and asynchronous capabilities.
No, yeah, I understand asynchronous and synchronous, but the way it listed here, I got a little confused. Okay.
Understand. I apologize for the confusing slide. Thank you for the question. Any other questions right now, Troy?
Not that I see in the chat box. Seema did mention not seeing the hand raise function. So Joanna wrote in the 3 dots. So it may depend on how your Zoom screen is set up, but mine is showing underneath the reactions function. So the reactions function will be on your toolbar where you can mute yourself, start or stop your video. And its reactions is a little smiley face with a plus next to it. You can click that, and then raise hand is the button. It should show up on the bottom of that. So just showing where the raise hand is, but keep going, Mitchell.
Thank you. So just showing some pictures of how this can be used. On the top left, that's an real-time interaction between a provider and a patient getting an assessment. On the right side, you're looking at a patient that's being monitored, whether it's in an EICU. Remote monitoring could be very similar. This one looks more like it's an EICU because this looks like a bedside device that the then technician is monitoring and would escalate based on alerts set for those parameters, such as SpO2 dropping below 90%. May set off a trigger, that'll set off alert, and there'll be a whole triage mechanism and response that you want to develop based on that. Some other tools we talked about that can be used, Bluetooth stethoscopes, exam cameras that can be used for dermatology, general use, otoscopes, etc. There is a lot more technology today than we probably can even imagine, but really the ability to do any of these tools. There's home diagnostics, home lab systems that are out there now today as well. And then just showing that this can be used in a clinic setting, like a cart, which is on the right, where you have that presenter that's trained to present the patient over the video to that specialist. You can see that in this sample, the specialist is actually reviewing a diagnostic image with the patients as well. And so that's one of the benefits is you can pull that up, you can still show that, highlight certain areas, you can even make measurements depending on the tool that you have. On the left is something that's really cool. This is actually a mobile unit that is deployed in ambulances, where they actually have this, where it has cellular connectivity or satellite connectivity, depending on the device, that allows these teams to present patients via telemedicine no matter where they are. This actually has an EKG ability. It has all those exam camera abilities and that functionality so they can triage a patient in the moment and determine what's the right level of care. When we think about some rural communities like Tonopah, Nevada, for example, they have no resources besides an ambulance potentially at certain times of the day. And so if we can avoid a transport, which could be a 5-hour round trip for that one vehicle, that allows that resource to be in that community where it might not have been before. And so if it's a minor suture or something that they can treat on site with the oversight of a physician, that's one way that we can engage and use telemedicine. And so I'm going to walk through a little bit of some of the different benefits, and I'm not hitting on all of them, but just throwing out some of the key benefits that we think about from a health system standpoint. You can deliver the right care at the right time. You may be able to increase access. What I think about is historically, if a patient has to come into your brick and mortar facility, that limits your amount of access points or touch points with the patient. But if we can allow the patients to connect via virtual modalities, how many more access points do we have around the community that patients can then use, including the ability to connect from their own devices at home? And overall, want to build a structure where it can really improve the care as well as help control the cost and reduce physician isolation. We hear this a lot in those provider communities that we're operating all these patients, but we don't see as robust different types of conditions. Having providers that we can use over video to support us, to engage, to share thoughts is always helpful as a force multiplier, and really thinking about collaborative care, because we know if the patient primarily gets the treatment in that rural community, they still may need to be transferred somewhere else after. And so that ability to truly collaborate on the right level of care and then repatriate those patients and allow that team to continue to deliver the right care for that patient is very impactful. And so for those patients, there's different value propositions for all patients, and I just highlighted a few that are rural versus urban, but we can think about incarcerated populations. How do they benefit from telemedicine as well versus civilian populations? Different payers may have different aspects, but really thinking for this session about rural needs, it's the access to the providers when there's not a lot of specialties that are on site in those rural communities. As I mentioned earlier at the very beginning, the access to providers is very low, ranked across the board, 48th to 51st with all 50 states across all specialties, primary care, et cetera. When we think about licensing and training, we have the ability to support and train providers and team members remotely. We can support them. We can use proxy privileging or proxy credentialing to allow those sites to not have to fully staff, but can use resources through that proxy mechanism. And additionally, just the opportunity cost for patients that have to drive this far. Do they have to sacrifice a day of work? Do they have to have a family member take time off to drive them? Will they just delay care or not get care because they don't want to do that? And so what's the sacrifice that it is? And we think a little bit more urban, it's more about convenience care. I'm too busy, the hours don't align, I've got kids. And so how do we make that convenient so that patients can get the right care at the right time? And as we transition over to rural, I'm going to pass the baton to Gary to talk about the rest that we have in store for you guys today. But I'll pause. Are there any questions, comments that you guys have at this time? Awesome. I'm hearing nothing. So Gary, I'll pass it to you.
Real quickly, Mitchell, yeah, it does look like Neil has a question.
Hey, Mitchell, thanks for that. And I was just kind of curious when there is, these screening tools that are used by like those mobile units and, these other things that you're screening, do they automatically sync up and embed themselves into the EHR of the patient? Let's say if they are part of a network, a doctor network or things like that, or even in a hospital?
So there are opportunities that you can do that. It typically requires an integration to be built. A lot of times we prefer not to at this time. I really think about it. The comparison we've had, which I think we're still evaluating and understanding, the biggest benefit is if it was a patient that was in front of us, would we record that and store that? If the answer is yes, then yes, we want to try to integrate that. If the answer is no, then it's kind of a gray area today with using technology. That kind of goes with recording video sessions when you're seeing a patient. There's a lot of benefits potentially with it, but you wouldn't record that if the patient was in your office. And so I think we're just tiptoeing on that gray line now, and I think that'll become more and more clear over time.
Got it. Thank you.
Great question.
Thanks, Neil. Amber?
Dr. I have such, I so appreciate your citing the number of hours that it takes for someone in a rural area to get to medical care. Our coalition looks at that in terms of a sexual assault victim, frequently riding in a car with law enforcement or who knows who to get care. So I really appreciate when you cite the exact number of hours that those people are having to go, however long they have to go. And I need to know, what is proxy credentialing?
Yeah, great question. On your first point, I'll say if you like that, what Gary has in store for you, you'll be even more excited about. But proxy credentialing is the ability for any provider to deliver care to a facility, they need to be credentialed and they need to have the right privilege at that facility. And a lot of these rural communities, their hospitals are very lightly staffed. And so to be able to get all these different specialties to get the right credential, it creates a lot of headache or a lot of resource challenges for them to do that. What you have the ability to do is if they are licensed, credentialed, and have the right privilege at the hub location, then you can pass that through proxy in a compliant fashion to the partner site so they can essentially allow their medical staff to accept the credentialing and privilege that they have at the partner site that's delivering the care. And that way they don't have to go through further burden to do that.
Yeah, yeah.
But it
removes
does
one more
require,
barrier, absolutely.
exactly. It requires
Yeah.
a medical staff to medical staff formal relationship between those facilities to share that information. But we found that it's really helping to increase access where a barrier was just the time it took to get the providers the right credential and the right privilege.
Yeah, yeah. Excellent. Thank you very much.
Thanks, Amber. Great question. Joanna has a question next.
Yes, I have a question. We're talking here about behavioral health, suspected child abuse and neglect, and domestic violence. When we're talking about that type of a patient, are there other individuals involved with any of the outreach telemedicine? Do the police officers or the EMTs or anything like that have ability to communicate to physicians back in the ER or into a specialty department to get the process started for these patients?
So I'll say around the country, the answer is yes. Some of those very mature programs absolutely have that connectivity through all the dispatching systems. For us today, actually, the unit that I showed, that was actually our local EMS agency that has that unit in a certain community. We would love to explore using that more and more in various other communities, but it's not something that we've at Renown built out yet. It's something that's on our roadmap. We'd love to get there. But absolutely agree that it would be extremely valuable and beneficial to have that up front.
Thanks, Joanna. And then the question as well.
Is it my name?
Yeah, go ahead, Seema.
Yes. So you listed the benefits here. How do you address provider burnout with all this technology use, multiple screens, multiple logins? And second thing is, how do you encourage patient engagement? Because with telehealth, it still is remote, and patient engagement for behavior health and so many for chronic disease is so important.
Yeah, those are two really great questions. So I think the first one, physician burnout, I'll say, it is a challenge. It's a challenge because a lot of these providers were not trained and did not go through medical school with this technology. I think important things are have a robust training program, set the expectations, make sure they have the right technical and training support at all times. so that they don't feel that. And honestly, I think it's about how you schedule with those patients to create that flexibility. So for example, for us, what we found is some of our providers found it challenging to go between in-office to virtual to in-office to virtual. And so what we've had them do is create blocks of time for virtual services where they're just focused on that, and then other blocks of time for their in-office patients. That's really helped streamline that. Our
So
providers have
Michelle,
actually,
so Michelle, yeah, those are good. But if we are talking about rural clinics, rural hospitals, they are struggling either with economics. Money is a big thing for them, and staffing. So yes, all those are doable things, but in reality, how much are those doable? Because I work on telehealth here in Oregon. I tell them all these great suggestions, but their biggest issue is staffing, and they don't have any kind of funds to upgrades or integrate, um, technology.
yeah, great question. I'll say that in another session, we're actually going to talk a little bit about creating sustainability, creating that ability to help with that funding, ways to assist. But one thing I think about is the rural communities that your work talking about is probably not alone in that they have those same issues. And what we're trying to do is pull together a group of rural communities to say, we do need this neurology support or cardiology support. And maybe it's now not that one site has to pay for that because, to your point, it's very costly, but maybe if there's 10 sites that are sharing access to one cardiologist to deliver virtual and telemedicine services across them, that's now a shared cost, but they now all have access to a cardiologist. And so it's mutually beneficial, and that it's allowing them to hopefully get the right care and the right service while also controlling the cost as much as possible. We look at grants and we look at other opportunities to create something that's more sustainable as well. But it's a really great question. Sorry, did I address that clearly, or is there any follow-up there?
No, that's good. Yeah, no, that's yeah, I think those are ongoing issues. I don't know if you know that's all. Those are tough in rural area. We know staffing and cost is a big issue.
Yeah, absolutely. And I'll briefly touch on your second question, which was patients and how do you get them up. I think a lot of times it's just let's address the stigma. Let's have them try it. The biggest thing for us is if we have the provider that sends the referral, let's say for a specialty, and we say, we really think that if I were you, I would recommend being seen via telemedicine. Here are some of the reasons why. Thinking about it from the patient perspective, you don't have to travel. You'll be able to get in a timely fashion. All the rest of the visit is the same. Typically, it's the provider that's referring that has the most impact on making the patient feel comfortable to try it. And after that, it's about giving the patient a very good initial experience, because we have the biggest volume we have is from patients that are using it multiple times. And I hear all the time now patients say, why do I have to come in for that service? I don't even want to come in anymore. So I think it's about giving them a great experience and making sure you're able to deliver that. Give them the tools to help them support it. What we try to do is do a test connect with the patients if it's their first time, 30 minutes in advance, or give them a portal to do a self-test for audio, video, and a support line to call out to if that's not successful, to help them get connected. A lot of what we do on the back end is watch the cameras too to make sure they're launching, getting connected. And if there is a disconnection, we'll try to proactively follow up and reach out and see if we can have our IT team interject and assist with connecting them at the time.
All right. One more question here from Hannah Barnhart, and then we'll turn it over to Gary. Thanks for all the questions and good discussion, everyone. Go ahead, Hannah.
I just wanted to kind of comment, so I don't want to take up too much time, but a perfect example of, I think, Seema's question, when I used to work in Alaska and we had to travel to various locations because of the genetics provider that we would fly from Washington or Oregon. We had a perfect example of the hub that Mitchell was talking about, how we had one hub, which is Bethel, which then serviced all of the Western rural clinics for Alaska. And what ended up happening is first we wanted to make sure that we got the support of the tribes that are represented in that Western region of Alaska. So that's the key part right there, is you want to make sure you have that communication and relationship with all the tribal leaders and all the tribal organizations, so that they're all kind of in the same boat. They're realizing this is what we need. And once you kind of make them realize that, they're pretty much, on the same boat, saying, okay, well, let's share the costs. And then at the same time, Seema was mentioning about staffing. What kind of spurred out of that is that the tribal council then realized, oh yes, we needed to staff it. And what they did is they partnered with the University of Alaska Fairbanks and University of Alaska Anchorage to provide training for that particular staffing need for the rural clinics. So they actually developed a program for the state just for that. And then as an end result, basically when you have proper communication with the community, great relationship, the right staffing, then you end up with, patients kind of being receptive to the appointment, and you kind of, destroy all those barriers. Just so an example for you guys to know.
Thank you for sharing that, Hannah. I really appreciate that example. It's great to hear that story. So Gary, I'll pass it to you. I know that I probably went a few minutes over with all those questions, so I apologize. But just go ahead and prompt me with next slide when you want me to advance.
Okay, thanks, Mitchell, and no problem with the time. I'll go through this quickly, but I do appreciate the pressure putting on me for what's to come. So thank you for that. But anyway, I think it's important for me to just review the learning objectives for my part of the presentation before I go any further, and hopefully I can provide you with a better understanding of rural health in our service area, identify some of the particular limitations and challenges that these rural hospitals and communities face. And I don't think they're exclusive just to our rural hospitals and communities. I think they're probably nationwide. And again, also describe why access to care is a significant concern in our service area. I'm then going to review a prospective strategic plan for rural health. And it's, of course, it's kind of biased and based on what we've done, but I'm trying to make it as generic as possible for just consideration of how to help these rural hospitals and communities in any way that you can. I'm also going to just briefly describe how tele-emergency care and telecritical care can eventually, and it's being provided now, but it can be very supportive of rural health. And then I'll end up with a summary of value-based implications of telemedicine in rural communities. So this is a map of our service area. And for those of you who aren't familiar with our area, it's a huge area, greater than 80,000 square miles. Northern Nevada for the most part, down to Tonopah, as Mitchell mentioned earlier, and then the eastern side of the Sierras in California, with some of these hospitals being as close as 30 miles away, and some of them, like Ely, greater than 300 miles away. And those cities and towns on the left, each one of those either has an acute care hospital or a critical access hospital, and that's why they're included in this map. Next slide. So I'd like to provide you with a descriptive profile of the service area, and then point out some limitations and challenges that these rural hospitals face. And like I said, it's not exclusive to our area alone, but in our area, we have 23 rural hospitals, 26 rural health clinics. We have 15 federally qualified health centers, and we also have, which I didn't mention, and I apologize, but we also have 34 tribal clinics in our area as well. Of these, there's 9 critical access hospitals in Nevada and 10 critical access hospitals in California. I just have to tell you, I'm originally from Iowa. Iowa is for the most part rural. And as a comparison to Nevada, it's about 70% the size of our service area. In Iowa, there are 82 critical access hospitals in that state. So it kind of boggled my mind when I found that out. I look at our area and what we have, and I look at what they have back there. I know several of those critical access hospitals in Iowa are in financial trouble for many different reasons. But fortunately, none of the critical access hospitals or even bigger hospitals are in financial trouble at this time. Some are borderline, some are coming out of bankruptcy, but fortunately, they're all viable and provide a great service to those communities. Several of these rural hospitals have no ICU beds. Some of them have swing beds, which we hope to utilize. Several of them have skilled nursing facilities within the hospital, as well as long-term care beds. And each rural hospital is unique. There's no two critical access hospitals in particular that are alike. So I've really promoted to our senior leadership and people that I work closely with, and Mitchell can attest to this. It is best if you go out and meet with these people, meet with leadership, see their facilities, find out about their services and their limitations, and find out what their needs are. And that's the best way to work with these communities and hospitals. So, in some of these places, it's a long drive, but it's well worth the time to go out there and see these facilities and meet the good people that work out there. With regard to limitations and challenges, as Mitchell mentioned earlier, there's a severe healthcare workforce staffing and service shortage here in Nevada, as it is across the country. And for those of you in behavioral health, you know that there's a lack of behavioral health providers out there. I'm sure you're overwhelmed by the number of requests that you get. Of course, there's a lack of availability of in some of these communities and counties of public health and social support systems. Cost barriers, of course, are an issue, as well as the rural poverty that is out there. There is transportation barriers. Not only are they driving great distances for medical care in some instances, but even local medical transportation is an issue in some of these communities. And like we mentioned, distance to tertiary and quaternary services, some of these are great distances and certainly a burden for those patients in those communities. And then, with regard to social determinants of health, there's poor health literacy out there, lack of healthy and nutritional food. Insurance is a big deal out there for these folks. And of course, for the hospitals, it's lack of reimbursement. And then because these rural hospitals are trying to sustain themselves, they probably do generate higher costs for those patients in some circumstances. So that has to be taken into consideration. I mean, to stay viable, they have to charge a higher fees for those services. But again, it's great that they're there, because then it saves the patients money in the long run if they don't have to be transported elsewhere for a higher level of care. Mitchell mentioned earlier about the lack of infrastructure, including broadband and mobile technology capabilities. And then, of course, the lack of interstate licensing, which right now it's been waived. The restrictions on that have been waived because of COVID. And that is supposed to last through the end of the year, but we'll have to wait and see, because it certainly does provide some barriers. It has in the past and potentially could in the future. Go ahead to the next slide, Mitchell.
All right, next slide. And I'm just going to give you a time check. We're about 13 minutes up to 1 o'clock here.
Thank you. I will be on time. So this is just a picture to depict what our service area looks like. And not only is it the fact that, the next hospital may be 100 miles or more away, this is the topography of a lot of our area. So there's a lot of empty space out in that area, but indeed it's a beautiful area of those that you've been fortunate enough to travel out there. Next slide, please. And I'd like to call attention to this with our affiliation with the University of Nevada School of Medicine. So in February of 2020, they had a report that came out that talked about the physician shortage and challenges and opportunities for growth. And they indicated in that report that the physician shortage certainly was going to be a greater burden for those rural regions in our area. And then thankfully, with the approval of the Nevada State Higher System of Higher Education Board of Regents, Renown Health and the School of Medicine has now gone forward with a 50-year-long affiliation agreement. And with this platform, we hope to enhance Nevada's medical education system, improve access to care, promote an expansion of clinical research and employment capabilities here in the area. And again, the goal is to create a world-class health network to meet the needs in this community. Next slide, please. Great. I just wanted to provide, and I'm not going to go through these now because of time, but it's just some highlights illuminating key findings regarding healthcare resources and economics in rural Nevada. It gives you a clear perspective of these rural hospitals here. And I do want to take the time to call attention to and give a plug out to our colleagues at the School of Medicine's Office of Statewide Initiatives, who provide a wealth of insightful information and data in their annually published Nevada Rural and Frontier Health Data Book. So if you're interested in that information, all this information comes from their 2021 publication. But certainly you can reach out to Troy in the Office of Project ECHO, and they'll connect you to the Office of Statewide Initiatives because they're a part of it, and you can have access to this great book. So
yeah, Gary, I will share a link to the webpage where you can actually download a PDF version of that.
Great. Thank you, Troy. Next slide, Mitchell. And again, for the sake of time, I'm not going to go through this. I think what I want to highlight is the fact that this is all the counties in our service area for both California and Nevada. And what we've done is looked at the percentage of in this case, it's uninsured patients, and the percentage of Medicare patients, the population to provider ratios for primary care, dentists, and mental health providers. It gives you an idea of the lack of access out there in these rural areas. So next slide. And again, this is just a continuation of access, and it really covers the rural hospitals, critical access hospitals, the rural hospitals PPS, and that's a payment system, rural health clinics, federally qualified health centers, and tribal clinics as well, and gives you totals for each. So next slide, please. And then this is just, I just wanted to shift gears a little bit and provide you with some concepts as what might be a potential rural health strategy for either larger acute care medical centers or anyone implementing what may be a hospital command center and a viable telehealth program. So the goal is, again, to improve access, quality, cost of care, and keep these rural hospitals financially viable. So through this command center and a telehealth program, the objective is to improve care for non-critical rural patients to reduce avoidable and costly transfers. And we certainly saw this come into play with COVID, especially at the end of 2020 and the beginning of 2021, because of our capacity issues, as there was capacity issues in many of the larger hospitals, as well as the rural hospitals as well. So we worked with these hospitals to keep patients in those communities and in those hospitals when we can, and only had them transferred just for a higher level of care. We also want to reduce out-migration. We want confidence. We want to build confidence in the patients and the communities that their rural hospital can provide services there. And if they do need a higher level of care, hopefully they can work with a partner to transfer those patients. And of course, I think education should be a cornerstone of a rural health strategy. And a great example is Project ECHO. The fact that you have the opportunity to be educated, get some continuing medical education, and bring up case scenarios to where you really can learn. And this is very advantageous for the providers and healthcare staff out there. We, in turn, provide evidence-based protocols and order sets so that if patients do need to be transferred to us, they're transferred in a sense that we're comfortable with, and bring them to our hospital for the higher level of care appropriately. And again, our goal is to provide the right care for the right patient at the right time in the right location. Now, next, our big goal has been to repatriate patients back to transfer to the transferring communities and hospitals for post-acute care when those hospitals and communities offer the services and that patient doesn't need a higher level of care. That's a win-win for everybody, because the rural hospitals get the benefit of bringing those back to either their skilled nursing, their swing beds, their long-term care, where they're utilizing the services provided locally. And then the bigger hospitals like ourselves will gain the benefit of clearing beds for those patients that do need a higher level of care, and it certainly helps with our capacity levels. And of course, our goal is to increase utilization of both inpatient and outpatient telehealth services. And I put down, it's not only to develop a strategic plan for each rural hospital, but I think rural hospitals need to partner with hospitals that are going to provide a timely and quality service to them as well. And hopefully, we're in a position where we're providing that service to them, but it's just a matter of collaboration, and that should be a key part of your strategy. Next slide, please. Just an example, and this isn't a new concept, it's being done elsewhere, but we've now taken the initiative to start this here at Renown. We've invested a lot of money into it, but again, it's to manage the inpatient flow from a centralized hospital-wide view for access, throughput, and discharge. And so I'm not going to go into that. I will tell you that we have a grand opening of our Transfer and Operations Center coming up August 2nd. For those of you that are in the rural communities and rural hospitals that we serve, you'll likely get an invite from me, so that if you're able to join us, we'd love to have you join us so that we can highlight what we're offering to you and your patients out in those rural communities. Next slide, please. And then I wanted to bring this to your attention because I think both tele-emergency care and telecritical care can be very supportive of these rural hospitals. And I'm not going to go through it right now for the sake of time, but just keep in mind that there are some great benefits. And again, the goal is to provide the right care, in the right place, at the right time, and to work with these rural hospitals to do that. You can go to the next slide too, Mitchell, but both tele-emergency care and telecritical care are so important that we're still making progress so that we're able to offer that to our partners in the near future. That's the next steps for us. We've already started with our remote patient monitoring, but these are the next steps so that we can provide that kind of service to our partners. Next slide, please. And I'll end it with a brief summary of what we feel are important value-based implications of telemedicine in rural communities. It does enhance the role and the reputation in the community. It will reduce unnecessary and costly transfers and outmigration. We all know local care is better care for both the patient as well as their families, and it does promote a standardization and a quality of care and a pathway to constant learning for caregivers. Again, Project ECHO. We want to keep those rural hospitals viable and sustainable. We want to provide the collaboration, again, to provide the right care for the right patient, the right time, right location, and use the resources to provide a high quality care at the lowest possible cost. And so we can go to the next slide. And that concludes my presentation. And Mitchell and I are both available for any kind of questions that you may have.
Awesome. Well, thank you, Gary. And I think we just wanted to show that there's many different communities that we support. They may look different, they may feel different, but at the end of the day, we need to work together to make sure every patient gets the right care at the right time. And it's something that we all know, that's from the questions and comments shared, that it can't be done and in a silo. We need to work together to address that mission from a public health standpoint. So Troy, I'll open it up if you have any questions in the chat or anyone has any questions that they want to ask at this time.
Absolutely. Yeah. Thank you so much, Mitchell and Gary. Great information that you shared with us here today. It looks like Neil does have a question. So Neil, go ahead, please.
Thank you, guys. Great. So impressive, the programs that you guys are embarking on. One of the questions that came to my mind is, as these mobile phone companies or cellular telephone companies are rolling out 5G, does that help in the sort of nearer term or even kind of midterm, as far as not having to recreate or create a broadband access for these rural communities where they can leverage that already existing cellular network when the 5G comes out?
So I'll say, yes, it helps, but particularly for our community in Nevada, I don't think it will address it. I say that because when I drive out to do visits to some of our partner sites across the state, I have reception to do phone meetings in less than half of the time that I'm traveling. And so when we think about that, even increasing to 5G, if I can't have a standard phone call, it's going to be very difficult to have a reliable video interaction. And that's why a lot of our partnerships with those communities go through a clinic to present the patient. And we're looking more at a telemedicine modality than a virtual visit modality to those communities. While I do hope that over time, that is a solution that can really help address it from a cellular perspective.
Thank you.
Yeah, great question.
Yeah, Amber, please go ahead.
I know that there are in other states, there are partnerships between healthcare providers and the state around boosting bandwidth in rural areas and making those services available. Is there, I don't know, and one of them has something like it's a consortium of, and they're actually addressing the issue. Is there anything here in the state that's doing the same? Any group, any offshoot from that's getting federal money? Anybody?
So I think there are groups that are trying to work on that now. When we look at the Nevada Telehealth Alliance, some of these other mechanisms that are groups that have formed to support that. What we've historically done, just sharing a little bit of our renowned experiences, we've applied for grants for technology equipment and telehealth equipment with communities, and we'll partner with the Governor's Office of Science, Innovation, and Technology to make them aware of communities that we're exploring partnerships from telehealth. They'll also then at that time explore funding that there are for broadband in those same communities. So what we try to do is go in tandem, where we have the OSID office get funding, deploy broadband first, and then we come in after, deploy telehealth technology after, so that we can try to ensure there is the right level of support for a successful interaction and launch. But love what your idea is, and I do think that as a community, whether it's statewide, whether it's regional, we really need to think about how do we work together to create those sustainable solutions. So I love that
Absolutely.
thought.
Thank you.
Thank you.
Thanks, Amber. All right, we are at time, but want to address any other questions you may have. Anything else out there? Feel free to unmute yourselves or write in through the chat box. Joanna, go ahead.
Won't the 5G actually help with data exchange as well? Not just the voice, but shouldn't that be able to, especially if there's like a failover SIM? So let's say that we have two providers within the area and one is weaker in a certain area, then they can fail over to the second provider to help send that information or that call or the data.
Yeah, absolutely. Again, I apologize if I didn't say it clearly. It'll absolutely help with all the different modalities of telehealth, but I don't think the way that our current state is, I have reservations of saying that 5G is the single solution that'll resolve our issues from connectivity. Knowing if you've driven through rural Nevada and you've driven across the state and you see where you have reception and where you don't, I think that'll help paint that picture. But I absolutely agree. It will definitely help that. And for those communities that get that, it'll be extreme value. But for a lot of these communities specific to rural Nevada, that's still a challenge today.